So welcome everyone. My name is Perry Kim. I'm the Assistant Scientific Director at the Canadian Frailty Network. I want to thank you all for attending today's webinar. To start, I'd like for all of us to acknowledge that the Canadian Frailty Network and Queen's University, our host academic institution, is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. Today's webinar is titled Results from Better Targeting Better Outcomes for Frail Elderly Patients, Advanced Care Planning Cluster Randomized Trial. Today's speaker is Dr. George Heckman, Associate Professor at the University of Waterloo. Now, before we get going, I'd just like to remind everyone that George will answer questions after his presentation. For those interested in asking questions, please post your questions by clicking on the Q&A button at the bottom of your screen, and I'll read as many questions as I can to George after his presentation. Just as a reminder, slides and video will be available on our website about 1 or 2 days after today's presentation. I also want to remind everyone that our next webinar is April 27th, noon Eastern Time. Title is Transforming Primary Care for Older Adults Living with Frailty. And our speaker is Dr. Paul Stoley, and also from the University of Waterloo. So again, I want to introduce our speaker today, Dr. George Heckman, a geriatrician, Slagle Research Chair in Geriatric Medicine, and Associate Professor of the School of Public Health Sciences at the University of Waterloo. His clinical research work focuses on health service research, specifically the care of frail older persons in community settings. I'm also told he's a glass half full Habs fan. I won't hold that against you, George, but would like to see any Canadian team win the Stanley Cup. So go Leafs, go. So with that, I'll hand it over to you, George, to share your screen and begin your presentation.
Thank you so much, Perry and Matt, for organizing this. And I'm very pleased to be able to share our science. I'm very grateful to the Canadian Frailty Network on behalf of myself and my collaborators and a lot of the researchers at the University of Waterloo who really greatly benefited from this, the availability of this network. We're going to talk about results of a clinical trial that we completed with funding from the Canadian Frailty Network, as well as Research Manitoba from the University of Manitoba. And our collaborators include the University of Waterloo, the Research Institute for Aging, the Conestoga College in Kitchener, and the University of Calgary, as well as the University of Manitoba. Here are my disclosures. None of them are pertinent necessarily to this presentation.
Sorry, George, I can't see your screen. I don't think you're sharing your screen.
Oh, allow me to do so. You know, it's only been 2 years of Zooms, so you'd think I know what I'm doing.
Yep, I can see them now, thanks.
Okay, so you've got my disclosures there. And I'm going to acknowledge my collaborators, Drs. Alan Garland, who's the co-PI for this study, as well as Drs. Keller, Quayle, Boscart, Ramsey, and Heyer, and acknowledging some of our other collaborators here. In terms of funding, we thank the Canadian Frailty Network, Research Manitoba, and I'm supported, as well as Dr. Boscart and Dr. Keller, by Slagle Research Chairs at the University of Waterloo and the Research Institute for Aging in Waterloo. And before we get going, all of the resources for this clinical trial, all of the educational material that we will talk about is available for free for anyone at the Research Institute for Aging website under resources /Babel. So feel free to peruse these during the talk or anytime afterwards, and feedback is always welcome. So we're going to talk about the rationale and framework for doing this trial in the first place. And we're going to go through the main steps of the project, which included a workshop with stakeholder consultation, how we developed the actual intervention, what the intervention looks like, and we'll talk about the trial itself and some of its results, as well as some conclusions and ideas for future work. So the challenge of long-term care really is never been so much clearer than it is now after the pandemic. We have a growing number of older persons in general in the society and community in Canada. We're not alone. Many of the countries around the world are facing this challenge. And therefore, we have a growing number of people who eventually reside in long-term care homes where they get support for their needs available 24 hours a day.
Oh, hi, George. Just sorry to interrupt, but you're not in presenter mode, you're in slideshow mode. So
Okay.
just to let you know.
Okay.
Great, thank you.
These folks face high rates of hospitalization and obviously high mortality rates. And what we've shown in some previous CFN related work is that in a very large retrospective cohort is that the hospitalization rates in the first 3 months in particular, and the mortality rates in the first 3 months after admission to a nursing home are particularly high. And the mortality rates at about a year hit 35 to 40% in some series, but you also see a very high proportion of people who require hospitalization as well. And many of these people are nearing the end of life, and they undergo a lot of this, arguably, and many people will argue, unnecessary interventions and transfers. And again, recent data that one of our colleagues submitted to the journal Medical Care was looking at the nursing home population in Ontario and was looking at a very large cohort of nursing home residents who were hospitalized and compared them using propensity matching to long-term care residents with similar characteristics who were not hospitalized. And many of these people were nearing the end of life. And what we found was that among those who were sent to hospital and survived the hospitalization and returned to the nursing home, they came home with greater health instability, worsening physical function, on more medications, suffering more falls, experiencing more pressure ulcers and bowel incontinence. And the monthly costs following hospitalization in these people compared to those who didn't go to hospital were approximately $2,000 more per month per resident. And so really this begs the question as to whether we are properly looking after these people nearing the end of life and how we might both improve their quality of life, preserve what they've got, and prevent needless interventions and transfers to long-term to hospital. My colleague John Hurdy's presented last week, and I thank him for this slide. These data that I just presented you were related to non-pandemic times, and obviously we know what happened during this pandemic, where a very high number of long-term care residents suffered from the COVID infections, and approximately 10,000 of the deaths in the first couple of waves were related to COVID in long-term care homes. So a very vulnerable, a very frail population with high event rates, which leads us to the concept of advanced care planning, which really aims to ensure that the care that a person nearing the end of life is concordant with their wishes and goals, assuming that we've actually given them the opportunity to express these. It's a process. Advanced care planning is a process. It's an ongoing process and conversation, and it's a process of reflection that an older person, or any person for that matter, undertakes in order to formulate and communicate their wishes for future health and personal care. And we know from previous studies, including some older clinical trials, that if we do this in long-term care homes, we can reduce acute care utilization, improve the quality of care experienced by the long-term care residents, and reduce the costs, or do so at no increase in cost. However, one of the rationales for our work was that despite this evidence, we knew that advanced care planning in Canada remains suboptimal. And In some jurisdictions in Canada, up to 50% of long-term care residents end up dying in hospital and do so with a high burden of symptoms. And so our approach in terms of advanced care planning really raises questions about whether we are doing this in a proper way to ensure that residents' wishes and preferences for care at the end of life are actually elicited properly and followed through with. We also noted that there's significant variability amongst Canadian jurisdictions. Some have rates of residents dying in hospital in the 25 to 30% range, whereas others, it's up to 50%. And that reflects some legislative differences that we had to address when we were developing this intervention. And so our goal was to develop, implement, and evaluate an advanced care planning intervention that would be both sustainable and scalable across Canadian long-term care sector. We use the CIHR knowledge to action process to develop our approach to this project, knowing that advanced care planning in Canadian long-term care homes was suboptimal based on a lot of data that is collected by the Canadian Institutes for Health Information. We also knew that advanced care planning works. And so what we did was to review the clinical trials that had been published, and we tried to identify the common design elements of these successful interventions. And I will show you what that looked like shortly. We then proceeded to a stakeholder engagement because obviously there was a gap between the evidence and its implementation in the sector, and therefore we wanted to speak with stakeholders, including residents and resident family members, about what the barriers were from their perspectives towards implementing advanced care planning in long-term care homes, which really relates to this adapting knowledge to local contexts, assessing barriers, and selecting and tailoring how we're going to implement the intervention. And finally, the rest of the project was to design the intervention, test it out in a clinical trial, and evaluate its effectiveness. So the workshop was held, it was a one-day workshop. It was held in Toronto, Canada in 2017. 44 stakeholders were invited. And these were predominantly from the 3 provinces where our investigators were and where we were planning to conduct the clinical trial, which is Alberta, Manitoba, and Ontario. There were 4 residents and their families, and there were clinical, administrative, and staff from these long-term care homes. Of note, despite being invited, no physicians accepted the invitation to come. And we'll talk about the role of the physicians subsequently. The workshop consisted of plenary sessions and small group discussions to review the advanced care planning framework that we had developed based on the common themes in existing literature. And we used recordings and notes and conducted thematic descriptive analysis. And this is what we started with based on the literature. There were essentially 4 main steps to advanced care planning based on the clinical trials which we had available at the time. Obviously, people at risk were of interest, and as we noted, long-term care residents have high event rates, and so most arguably would be at high risk. And the preliminary approach was to determine whether advanced care preferences were already established and whether a substitute decision maker had been identified, and also what the resident's ability and capacity for decision making was. So generally, those are some of the preliminaries that are common to most interventions. The second step was to frame the patient's goals, or to try to get the patient to express their goals within the context of their current health, which would require, obviously, that we would have accurate resident health information to share with them, as well as prognostic information so they would understand their expected course with certain conditions and what complications might arise and what decisions they might have to consider. Now, this is important because in many advanced care planning directives, relatively hypothetical scenarios are presented for people to consider, and these may not be necessarily related to their own personal health status. Subsequent to that, the idea was to frame potential treatment options within the person's context of their health. I'm sorry about that. And so starting with the more common ones are related to resuscitation and hospitalization, but then including potential operations or interventions, medication prescribing, and symptom control, and how to respect resident goals with the knowledge that their health will deteriorate and that their perspectives on these different options would likely also evolve. And finally, the last stage was reviewing, reconsidering, confirming, and updating, essentially whenever a person gets worse, but at least on a basis that is fairly regular so that the concept is not forgotten and the resident has an opportunity to update their wishes and reappraise their current health and reframe their wishes based on this, their health information. So the findings from the workshop, and I've got the link to the reference there, it is open access, was that different provincial frameworks exist with respect to advanced care planning and particularly consent, whereas some provinces, such as Ontario, insist on consent being done every time a decision must be made and for every single decision, with the underlying understanding that capacity may vary. Capacity to accept a vaccination may be possible, whereas capacity to understand something like chemotherapy may not be. And therefore, Ontario has a decision-specific approach where consent is only obtained when a decision is required, and capacity of the resident must be assessed for each decision, versus other jurisdictions where capacity is considered a blanket statement, and therefore the resident may or may not be able to participate or asked to participate in conversations where the substitute decision maker then becomes the de facto person that they go to. There were weak links identified in successful advanced care planning. The big one was lack of clarity on the identity as well as the role of the substitute decision maker. Often this person is not well known to the care team, and often this person assumes that whatever they think is appropriate goes, as opposed to their true role, which is to represent the wishes of a resident who may not be able to express them at the time a decision is needed or at all. Another weak link was the failure of the care team in the nursing home to share specific health-related information to the residents so they could properly contextualize their wishes. The glaring one is CPR. If you watch television shows, CPR is always successful, and that's the impression people have. And whereas in long-term care, even if it were successful, the functional outcomes, which matter more to the person often, are not well understood. Health crises and communication during a health crisis was also an important point of weakness, whereas often the family has not been appraised of the person's wishes with respect to advanced care planning. And often it's an on-call physician who may not be aware of things and will devolve to the option of sending the person to hospital. And physician involvement is highly variable, and whereas some physicians are highly involved in these conversations, others are not. And so that was identified as another weak link. The conversation, the workshop suggested specific knowledge products for long-term care holders. Many of those currently used in Canada were cited as being very helpful, but others were recommended because sometimes people will not have time to read fairly large documents, and there was a need expressed for briefer knowledge products for long-term care stakeholders. And finally, the importance of the ongoing aspect of the conversation was required. And while a conversation may happen upon admission to the nursing home or shortly thereafter, often the conversation is not repeated on a formal basis. So those were the four themes related to the situation regarding how we might want to improve advanced care planning based on the stakeholder workshop. We then conducted a pre-trial survey of long-term care advanced care planning practices in the long-term care homes that had volunteered to be part of our trial. And this was about 27 to 30 long-term care homes in the 3 provinces that I mentioned. And again, this is available at the reference right there with the link, and it's a open access paper as well. So you are free to download it as you wish. And what we looked at was a number of things, but I just want to show you some of the key findings in terms of who gets to participate in advanced care planning decisions. And we looked at how often this happened, looking at low frequency, intermediate, which was about half the time, and high. And as you can see, residents are often not active participants in advanced care planning discussions. Even though they might have cognitive impairment, they still have something to say and a wish to express. So that was notable. It was often the spouse or the children who participated. In terms of the clinicians, mainly nurses were the ones who were participating in these, and physicians present in about 40%, but notably rarely involved in about 30% of nursing homes in advanced care planning decisions. And social workers were the other most commonly involved care provider. When it came to urgent decisions, we can see a little bit of what's going on is that, again, the resident is not necessarily involved in these. It's essentially a discussion between the nurse and the physician about what to do. So these were some of the results from a pretrial survey of the long-term care settings we were going to work in. We then set about designing the intervention itself. And again, we started with the workshops, its weak links, and the information we gathered on the desired knowledge products. As a team, we adopted a consensus process to work through the information from the workshop, and we developed the intervention over 11 months. We designed it to be delivered by nurses, given the variable physician involvement. We strongly encourage physician involvement, but we were cognizant that this might not always be the case. And so we were very careful to make sure that this could be designed by nurses. And when we develop knowledge products, we would conduct ad hoc focus groups with the intended target, be it long-term care clinicians, nurses, physicians, or residents and their families. Our design parameters were this. We wanted this to be person-centered as much as possible. And so the intervention emphasizes person-centered communication and exchange of information that is pertinent to that person, really personalized health information. So if a person has Parkinson's disease, for example, and has started to have difficulties with coughing when they eat, that, for example, puts them at risk for aspiration pneumonia. And so when we were talking about the prognosis and the journey they might expect, we focused on those aspects of their health, as opposed to saying, hypothetically, what would you want us to do if you developed a bladder infection or cholecystitis? We personalized it that way. We wanted to make sure that that the intervention was as sustainable and realistically doable in the context of the long-term care home. So again, we did involve a lot of long-term care staff in the development of this. We wanted to make sure that this was compatible with all these local regulatory frameworks, especially regarding consent. And for the intervention itself, we thought that we would begin by targeting residents with a high probability of death or medical emergency within the next 6 to 12 months after admission, based on indicators that are widely used in most Canadian long-term care homes based on the Inter-I MDS. And so we picked admission CHEST scores of 3 or above, and these reflect a high health instability with approximately a 50% event rate in the first 3 months, leaving more than 25% of their food uneaten, or an underlying diagnosis of congestive heart failure or active cancer. And we wanted to make sure that the intervention was scalable. So we tried to design all the materials and tools to enable self-implementation as much as possible, to try to make it as user-friendly for the teams and the patients and residents and staff and team members, make it as easy as possible for them to use. So the intervention itself has the following overall goals and stages, and I will go over them in greater detail shortly, but the first step is to confirm and identify the substitute decision maker and make sure that the role is clearly identified. We want to make sure that everyone is prepared both intellectually and emotionally for medical emergencies. We don't want to spring any surprise information on anyone during a crisis. It is not the right time to do so. We want to make sure that we are able to explain to the resident and their substitute decision maker their specific clinical situation and prognosis, and I gave the example of Parkinson's disease. We wanted to ascertain broadly the resident's decision-making approach, and then start talking about potential treatment options for the medical problems they're most likely to face. The idea was not to write specific orders. Again, that is forbidden in Ontario law. You cannot write an order for something that is not required or for a decision that is not needed currently or in the future. The materials themselves include a workbook, and the workbook really goes through these different steps and has carefully worded scripts to help staff learn how to approach these topics and help residents and families navigate these sensitive issues. There are actually two discussions. One's a preliminary discussion, and that is intended to take place soon after admission. And that's based on feedback that the CPR status has to be dealt with in a regulatory fashion as soon as possible. And so the preliminary discussion is done fairly early and introduces the concept of the BABEL discussion and addresses the issues of who's a substitute decision maker and what are the main wishes regarding resuscitation. And subsequently, the more in-depth full BABEL discussion takes place, and overall, the conversation takes about an hour. We include training tools for long-term care staff and knowledge tools for all of the stakeholders involved, including the residents and their family. So a bit of a deeper dive into the design principles. This is a paper that's going to be submitted to JAMDA shortly, so hopefully it will be available for you soon. So I summarize the contents of that paper. So the first principle is optimal communication requires time for the nursing home team and the resident to come to know one another. We all know that it's a tumultuous time, and the publicity on long-term care homes over the last 2 years has not helped at all. People are suspicious, they're scared, they're frightened coming to a nursing home. They don't know what's going on. They don't know the people looking after them. And so ideally, you want to have time for them to get to know and trust the team. And that's why we held a full discussion later. We have the preliminaries addressed fairly quickly, but we don't force the issues until there's been some time for people to settle in and get to know their team. The second principle is ideally the physicians should be able to participate. And so while we designed the intervention to be delivered by nurses, we were very clear to specify the specific roles where physicians would be ideally suited for. And so that way, if there are timing issues or billing concerns for the physicians regarding advanced care planning, these could be specified by the nursing team and made to be very specific and short and sweet, and so allow as much as possible the physician to participate. We emphasize that residents, even whether they are capable or not, should participate in advanced care planning discussions. The resident may not be able to understand the intricacies of coronary artery bypass surgery or an aortic valve replacement, but they can tell us what matters to them. And we emphasize the importance of having them involved in these conversations as much as possible. We focused on clear communication, and that's why we laid out the conversation scripts in the workbook. We made sure that specific topics are addressed in a specific sequence so that people can learn about this. Eventually, they're encouraged to come up with their own approach, but we wanted to make sure that at the very least, we were as comprehensive as possible and as sequenced as possible so that people could have something to start with. We wanted to avoid technical, coercive, and technical and negative terminology, especially the CPR stories where the emphasis is on the gory aspects of CPR, as opposed to the functional ones, which matter more for the resident subsequently. We wanted to make sure that symptom control was deemed an active intervention, because often what we don't say matters as well. People assume that we are trying to deny them treatments for this and that, but we never express symptom control as something important that we will continue to provide. And they get frightened when they don't hear that. And each step, we make sure that there is a check back, so that we make sure that the team doing the conversation ensures that the resident and substitute decision maker are understanding of what's going on. In terms of the weak links, we explicitly describe how to identify the substitute decision maker and ensure that this person and everyone else understand that person's role, which is to explain a resident's wishes and not superimpose their own wishes and preferences. We wanted to discuss the person's overall philosophy of care and then discuss their risk and their wishes in terms of the medical complications they're most likely to experience. And we also wanted to spend time to prepare everyone for the potential medical emergency that might arise, and to remind them that they will be supported in doing so, even though obviously it's a time that is fairly trying. But we do know from our stakeholder group and other literature that often it's in emergencies where substitute decision makers are not well prepared. And in the excitement and fear, they essentially will override what the residents might have previously expressed as a wish, and often send the person to hospital. And finally, make sure that people understand that this is a conversation. Admittingly, the capacity of a resident may change over time, and that is why we've integrated assessment of resident capacity into these conversations. And recognizing that capacity really depends on the complexity of the decision being considered, and not necessarily the extent of cognitive impairment. And so now to the trial. So the trial was registered at clinicaltrials.gov, and it was an unblinded cluster randomized mixed methods trial where the long-term care homes were the clusters. Long-term care homes were randomized to being intervention homes or control homes. And as previously mentioned, the trial was conducted in Alberta, Manitoba, and Ontario. We recruited residents over a 2.5-year period. Eventually, 713 residents were recruited, 442 in the controls and 271 in the interventions. And the fact that there was some imbalance there really relates to the fact that it took us a longer time to train intervention homes than it did control homes. The residents that were being targeted included those who were over 65 years of age and had a high risk of death at 12 months, again, using the indicators we previously mentioned. The outcomes we were interested in were co-primary outcomes of the audit of advanced care planning, which was an instrument designed by Darren Hayland in Kingston. Scores go from 0 to 7, and higher is better. And then the comfort assessment in dying, which is another instrument that is rated by the family members regarding the quality, so to speak, of the dying process. And again, higher is better. And we wanted to do that because we were interested in whether among the residents that died, whether advanced care planning had an impact on the quality of that death in terms of symptom control. We looked at a variety of secondary outcomes, including mortality, hospital transfer, ICU stays, antibiotics, and medical interventions in general at the end of life. And we, for those who were able to respond, self-efficacy of advanced care planning. And finally, there's a qualitative component to that I won't report on because analysis is still undergoing, but we interviewed a lot of the staff who were implementing the intervention to get their feedback. This is the audit of advanced care planning items, and I will leave that. You can have a look at it at your leisure. And so in terms of screening, this is the pathway of the trial. Around 3,300 residents were screened, and of these, 1,800 were found to be eligible. Ultimately, a relatively large number of them died. A lot of people die within the first 8 weeks of being admitted to a nursing home, regardless of how assertive we want to be. And we can talk about the implications of that in the discussion later. So ultimately, there were 442 controls who consented and 271 intervention patients. Of the intervention patients, 214 of the 271 survived long enough to get a full BABEL discussion. The others had the preliminary discussion and part of the full one. This is what the residents looked like in terms of the distribution. So actually fairly good recruitment in all provinces. The age was close to 88 years old. And I remember doing my first research projects in long-term care about 15 years ago, where the average age was in the lower 80s. So these residents are getting older. Most of them were women, consistent with previous literature, and about 30% of them had heart failure. Many of them were leaving their food uneaten. About 16 to 20% had a history of cancer, and about 11 to 18% had an elevated chest score. Very few were receiving active palliative care at the time. Behavior level scores were relatively low. Cognitive performance was about 3 out of 6. That is one of the MDS scales. A CPS of 3 means a mini mental of about 15 to 16, and a CPS of 3 is fairly typical of newly admitted long-term care residents in Canada. There was a modest burden of depressive symptoms, and pain was relatively well controlled for most. In terms of ADLs, most people required significant assistance for most basic activities such as dressing and transfers. Most advanced care planning discussions were held by nurses as we anticipated. Physician involvement was actually lower than we anticipated at about 18 to 19%. Overall resident outcomes, mortality rate was about 38% for the residents involved in the trial. There was a trend towards a lower mortality rate in the intervention group, which is reassuring. Often people will fear that advanced care planning discussions and choosing not to have treatments or go to hospital will result in higher mortality rates for residents who choose these options, and we showed that it was not true at all. And previous studies have shown similarly that advanced care planning discussions and wishes that are quote unquote less interventional do not lead to a higher mortality rate. So that was reassuring. About 27 of the patients in the intervention were transitioned to palliative care, with again a non-significant trend favoring the intervention group. In terms of the co-primary outcomes, there was improvement of about 60% in the comprehensiveness of advanced care planning. And so the feedback was that the intervention led to better, more comprehensive advanced care planning. In terms of comfort assessment in dying, there was actually no difference, and which suggests to us that once death is recognized as imminent, nursing homes in Canada tend to provide good palliative care. I don't have the absolute results there to show you, but the actual comfort in dying assessments were quite good. And so the experience of death, the symptom control at death was quite good, regardless of whether you were in an intervention home or a control home. In terms of secondary outcomes, to us, one of the most interesting ones was that we reduced the use of antimicrobials at the end of life by about 20%. And we did adjust for for false discovery rates when looking at multiple secondary outcomes. And this finding remained stable. And in fact, the finding was most notable amongst intervention residents who received the full discussion. And that was also statistically significant. So of those who had the full discussion, there was a reduction of about 27% in the use of antimicrobials. And this is quite notable because there have been many attempts to reduce antibiotic use in long-term care homes, and the success has been mixed. And so in this case, the advanced care planning conversations appear to have had an impact here. In terms of interventions, there was a trend towards slightly more interventions, but this was interestingly enough, we were trying to figure out what is going on there, but our hypothesis, and we will see what the qualitative data show, is that residents and substitute decision makers were more engaged in conversations about the interventions that they might have to face and appear to have requested more chest x-rays and blood work in order to potentially inform their final decision. We don't know yet, but we found that as an interesting finding. And finally, overall, there was a trend towards fewer ED visits overall. And among those with the full Babel discussion, this trend did achieve significance. But we do suspect, as we show, we will talk, that we did not achieve the sample size that we wished. And so we do suspect there was some type 1 error here. As I mentioned, the qualitative analysis is underway. We've had a peak, and the preliminary information suggests that staff learning how to do the intervention suggested that they were more comfortable and felt that the conversations about advanced care planning were improved. And there was also better documentation of advanced care planning wishes and decisions for residents that were easier to access for on-call staff. Challenges: doing nursing home long-term care research is really hard, and we knew that, but our recruitment rates of 50% was lower than what we previously experienced as researchers in long-term care. And whether that is because of temporal trends or whether that is because we were interested in higher risk individuals who might be more fragile and the families understandably would have wanted to protect them, we don't know. But long-term care research, seeing people in person, while so important, is extremely hard to do. And as a community of researchers, we need to think about how we make this more possible. Physician participation was low. And we are now looking, we have some extra funding left behind, and we are going to be asking physicians in long-term care how we could facilitate their involvement in this kind of conversation, because they do have an important role to play. The time for the intervention seems a lot, 60 minutes, but one of the comments from the qualitative research was that, this really relates to how we've organized care processes in long-term care homes. And one person noted, interestingly enough, that a director of care noted that, when they had a resident who was clearly at the end of life and had inadequate advanced care planning conversations, had become ill in a control home, this person was sent to the hospital, stayed there several days, died hours after nursing home repatriation. And they commented that the time spent for gathering documentation, calling 911, preparing the resident, making sure the transfer happened, and then getting the resident to come back to the nursing home was far in excess of the 60 minutes of the conversation. And so we have to really think about how can we alter care processes in long-term care, and in order to do the right thing. This intervention was developed based on stakeholder feedback. These were long-term care stakeholders who said, ideally, this is what we need to do. And so if that is what they think is what we need to do, how do we actually fit it in more seamlessly into the care processes? So in summary, we found that the BABEL approach to advanced care planning in long-term care resulted in more comprehensive advanced care planning. There was no difference in the comfort of dying in the homes in the trial. We appear to have decreased the use of antimicrobials. And we think that the per-protocol analysis that we've conducted, again, it was Posthoc, suggests that having the full BABEL discussion is the influential element of the intervention. Person-centeredness is key. And so what BABEL does is tailoring the conversations by sharing specific health information, helping the resident best understand what they have to face in the future and how that might relate to their care goals and wishes, and how the interventions might relate to their care goals and wishes. And the paper will be out shortly in Age and Aging, where it's been accepted. So I will stop now, and I'll stop sharing my screen and entertain any questions. Thank you.
Thanks, George. That was a lot to think about, for sure. I just encourage everyone to that's listening to post your questions by clicking the Q&A button again. So maybe we'll just jump right into it, since we don't have a lot of time. So George, the first question, sometimes a trusted person in long-term care is someone other than a nurse. Any thought of having other professionals on the floor communicate with a resident?
I presume the substitute decision maker. I think that's really important. We know that in long-term care homes, 80% of the contact with the resident is by a personal support worker. And they know that person intimately, right? They perform fairly intimate procedures. They know that person intimately. They're the confidant. And I'm sure that very often I've been told that as a physician, even though I try to make my lingo user-friendly, I fail. So people always ask the nurse, what did he say? Even though I thought I was clear. And I'm sure that happens with nurses. I think there are potentially professional legal requirements that mandate that a certain documentation must be done by a certified professional, but that's the end goal. I think engaging the personal support workers in this type of conversation should be important to do. And we didn't look at that. We basically allowed people to implement things as they wished. And nurses were the ones to do it. But in my own practice, I use the BABEL principles, but I do engage with the staff and the team and try to get a sense, bring them to the family meetings and try to get a sense of what they know that the resident might want because they've heard it before. So I think it's a very important conversation.
Great, thank you. I'm just curious, George, in you being a geriatrician, I'm curious, when do you sort of approach the discussion about ACP? It seems like it's late in the game to start introducing ACP when an individual is in the long-term care as opposed to well before that. Any thoughts on that?
That's a great question. When I first started off, I was very naive. Well, I'm still naive, I suppose, but I remember once early in practice meeting a resident or patient who had congestive heart failure, and I simultaneously gave a conversation about why we need to optimize medications and then jump straight into the CPR. And you know, in retrospect, I was saying, do all of this stuff so you can live longer, but you're going to die anyway. And so obviously you've got to be very careful about how you relay this. I think it's important to know who they are. And very often, you know, the CPR is the first one that we really want to talk about because they've already heard the story, but it's how you do it. And so as a geriatrician, I approach it using the BABEL principles. And we talk about, you know, what do you think? How do you think your health is? And what should we do? You know, you have Parkinson's and you're telling me you're choking, you might get pneumonia. So what are we going to do about that? What are you thinking about that? And it's a sort of I don't want to think, it's not an indirect way, but it is more of a specific conversation opener. And most of the time, people are very willing to have that conversation. And then you get into the broader conversation about goals and wishes. Pneumonia is a very good one to do. Dialysis is another one. Those are big decisions for chronic illnesses that we often see. Heart failure, COPD. Often going to hospital is something that you'd like to try one more time. And I can't argue with that. But when they come back from the hospital, often you'll say, how was it? And they will tell you, it was awful. It was noisy. Dad got delirious. Now he's worse off. And I think we need to reopen the conversation. So that's how I would approach it. From a system perspective, though, people go onto a long-term care wait list, and they may wait a few weeks or a few months. And they're sitting around somewhere being managed in the hospital in an ALC unit or by home care. And the question arises, why can't we start it there? And I think that's quite reasonable to do so. From a system perspective, if the conversation has already begun, then they will come to the nursing home. And especially for those who are so unstable that they will die in the first few weeks, you'll have a leg up there and be able to pursue the conversation that's already been started.
Great, thank you. I think you've sort of touched upon this, but the next question is, how long do existing ACP discussions take?
It's highly variable. I was just eavesdropping on one this morning, and it was quite quick. So there's a form. Basically, the form is CPR is the top one. The second one is, where would you prefer to die? People say, I prefer to die in the nursing home, and then you tick that off, and then you move on. And so it can be very quick, and it's certainly not focused on the person's health condition. It's more of an exchange. If I came up to you and say, so what do you think? Do you want to go to hospital or not if you get sick? And there's no context there, right? And obviously we're conditioned to think that hospitals are good places to go to. And so we often say, sure. Then we say, well, if you think we're dying, where would you like to die? And then people will say, okay, maybe I'll die in the nursing home. But that's it. And when the crisis happens and they have a bad COPD exacerbation or pneumonia, the nuance that we would have required in that early conversation hasn't taken place. And so often they'll say, let's go to the hospital. So the answer is not enough.
Okay, right. Thank you. Another question. How did you communicate risk and prognosis? Did you use pictures, numbers, time left, etc.?
So we have a number of tools in the workbook. We use pictorial diagrams. And I don't know if you have enough time, I could probably find one in the workbook. For example, CPR. We used the literature to look at what the data says, and we provide the data, but we have basically a diagram that shows, say, 100 nursing home residents having CPR, and then 1 month later, there's 3 left alive. And so it's very visual. And then there's a note that says, of those 3, 2 of the 3 have a worsening neurological outcome. And so that's the information that is shared pictorially and in a conversation. And we don't even go talk about the broken ribs and all the gory stuff, which is offensive and it's true, but it's offensive and we're trying to frighten the person in a way. Basically we say, this is what we can anticipate. If we are successful with CPR, this is what you will anticipate in a month. And then they go, well, wow, that's not at all consistent with my goals to preserve my cognition and my function. I don't do that with pneumonias, we do that with heart failure. And so, and again, we are hoping that people will look at this and think of other decisions that could be made, and we'd be happy to work with them to come up with additional tools for different conditions.
Great. I think this will be our last question. Are there supports available for residents who may have cultural traditions or needs that are different than those of the person having the conversation?
So that is mentioned in the workbook, but we did not have the bandwidth to delve into that because I think it's critical. I think everyone recognized that we need to understand the person's cultural approach to things. We need to understand their religion and how they make decisions. But this is a gap in the literature. And I think that is critically important. There are long-term care facilities that offer services to persons of a specific ethnic background, but by and large, most long-term care facilities have these folks as minorities and are not specifically catered to them. So I think that's a critical gap to fill in the literature.
Yeah, absolutely. So we are coming up to the top of the hour. So I want to thank you again, George, for taking the time out of your busy schedule. I know you've got a lot going on for presenting today and answering all these questions. And lastly, I want to thank the audience for, again, attending our webinar. And just remind everyone that our next webinar is scheduled for April 27th at noon. With that, I'll again thank you, George, and we'll see everyone soon. Bye-bye.
My pleasure. And please look at the sources. Please get in touch with us. We're happy to keep working on this with you.
Great. Thanks, George.
Thank you.